Good morning, everybody. Welcome to Ground Rounds. Today is a very exciting day. Our medical students are presenting the research projects. We're going to start with Sarah Svetec. Go ahead, Sarah.
Yeah. Hi, everybody. I'm Sarah. I'm a fourth-year student here. And I'm going to be presenting this project that looked at the impact of telehealth adaptation on the diagnosis of hypertensive disorders in pregnancy. And this was practically Sarah Abelman's brainchild, but lucky enough to work with her. So some background information, I think, kind of goes without saying, but this was looking at hypertensive disorders of pregnancy because we know how prevalent they are and how large of a contributor they are to maternal mortality, morbidity, and infant morbidity as well, with kind of the goal of management of these disorders to prevent severe features, including eclamptic seizures. And we all know that blood pressure monitoring is very central to these conditions, but so are kind of symptoms reported by patients, physical exam, and lab values. And the second part that led to this project is the COVID-19 pandemic that led to the adaptation of telehealth visits throughout many different parts of healthcare. And telehealth really had to be weighed kind of the risks of to health for providers and for patients in terms of acquiring COVID-19 versus the benefits of in-person visits, such as that those physical exam findings that can't really be done over the phone or over visually too. And just important to note that not everyone has the same access to telehealth. And not all telehealth visits are the same based on kind of patients' available access to internet and the devices they use. So differences in kind of both the video and audio quality can really have an impact on telehealth. So kind of all this together led to the kind of two questions that this research was looking at was, did the use of telehealth during the pandemic lead to a delay in the diagnosis of gestational hypertensive disorders? And did it lead to more severe diagnoses of these disorders? And so what we did to actually examine these questions was to do a retrospective cohort study. We are comparing two cohorts in 2019 and 2020, with 2020 being a year of the pandemic when telehealth was started to be implemented more commonly. And we did a chart review that looked at many different factors, with the primary outcomes we were looking at was the gestational age of diagnosis of hypertensive disorders. But then the secondary characteristics that we were collecting for with chart review being the severity of initial diagnosis, the most severe diagnosis received at all before time of birth, the gestational age of delivery, the mode of delivery, any sort of complications with delivery. So what we found, so we were able to do chart review on almost 500 patients, pretty evenly split between the 2019 and 2020 cohorts. And overall, 17% of patients ended up having severe features of preeclampsia initially, with about 30 meeting criteria at some point before delivery. And kind of not surprisingly, about 80% of patients in the 2020 group did have at least one telehealth visit, which was a dramatic increase from less than 1% in 2019. But interestingly, when comparing just the 2019 cohort and the 2020 cohort as a whole, there was no difference found in the gestational age at diagnosis or the diagnosis severities. Kind of some secondary analysis looking at what is associated with severity of initial diagnosis or final diagnosis. Black race was found to be associated with severity of initial diagnosis as well as final diagnosis. And then Hispanic ethnicity and high BMI were associated with the severity of final diagnosis as well, versus the cohort years and separating based off that was not associated with either of those. So kind of overall, the conclusion that was made off of this data was that the adaptation of telehealth kind of generally in 2020 for most patients was not associated with a change in the timing or severity of diagnosis of hypertensive disorders of pregnancy. But some kind of, I'll list some limitations first. So this is a general comparison of 2019 versus 2020. And we know that 80% of the patients within the 2020 cohort did utilize telehealth in some manner, but we weren't necessarily personalizing it to patients within 2020 who did receive telehealth interventions. But strengths of this research study are, I think, the large sample size of about 500 patients, which with each patient requiring some pretty intensive chart review, and also just the timely subject and how much this does have an impact on both patients as well as ourselves. And that's just kind of the forefront of our minds as we had to adapt telehealth measures in order to be more safe. I think something we were all thinking about was, how does this impact patient care? And how will this impact something like gestational hypertension disorders, which have such a large impact on maternal morbidity and mortality, like I said. So kind of some future directions that I can see, but just within our data set, because we did collect some more variables that weren't even analyzed in this first iteration that we published in an abstract, or we submitted for publication of an abstract. I think we can do more within the 2020 cohort itself, because we were able to collect data on what was the visit prior to diagnosis of a disorder, was the visit online or was it in person? And I think looking at that could be really interesting. Does having a telehealth visit right before you're diagnosed make you more likely to have a later gestational age of diagnosis? As well as we were able to collect how many telehealth visits each patient had. So we could look, kind of like dig a little deeper into the data that we collected ourselves. But then I think kind of broader strokes that research can be done to look at kind of more specific protocols for the ideal like timing of telehealth visits. Are there kind of ideal gestational ages where telehealth visits make the most sense and don't actually have any risk of kind of a delaying diagnosis of these kind of disorders? And then additionally, I think kind of something that popped in my head, and some of the visits, patients were taking their blood pressures at home for themselves. We weren't really able to analyze that in this study, but kind of looking at, is there a way to optimize telehealth visits? Does having patients take their blood pressure at home actually improve any of these outcomes? So I think there's a lot more that can be done, but that our study was really interesting. And I'm glad to see that the 2020 cohort didn't see a delay in diagnosis and increased severity of diagnosis. Yeah, I'm happy to answer any questions or any comments.
Excellent, Sarah. I'm really looking forward to have more information about this study. I just wonder about the ability of the different groups to reach providers from home, not just telehealth, but from home, because I know the Hispanic group in the Latino clinic had difficulties with telehealth, and they couldn't reach providers in the same way. They have to come in person. So did you look into this?
Not exactly. It was kind of just like, was there telehealth or not? Kind of like I mentioned, and you mentioned as well, telehealth isn't all the same. So kind of looking at quality of telehealth, or even looking at like video calls versus just doing audio calls, because so often quality is poor and you have to convert during the telehealth visit. Yeah, I think that's really interesting, but this study didn't really look at that.
Another question is, what blood pressure was used to meet the criteria for the hypertensive disorder? Was the one taken at home, or it was the confirmatory one in clinic or in the hospital?
Yeah, it was always in the clinics. I don't think really ever blood pressures at home were taken into consideration. I think it still required the two blood pressures taken in office visits or in triage. So this one wasn't looking at as much at the home blood pressures, but I don't think they were taken into consideration for the diagnosis either.
Great. We have one question in the chat. Whether the telehealth use was associated with larger gestational age diagnosis, like patients who had more telehealth use diagnosed later versus those that had fewer telehealth visits?
Yeah, no, that's a great question. So we were just kind of looking at 2020 versus 2019 in this first analyses. And we found that there wasn't kind of a later gestational age of diagnosis, but kind of looking at specifically patients with more telehealth visits, did this delay diagnosis is something that I think we can do with our data set, just having it.
Great, thank you so much, Sarah. Do we have any questions? I think we have 1 minute left. Okay, hearing none. Thank you so much, Sarah. Wonderful research.
Thank you.
Looking forward to run this and have a publication. Our next speaker is Maria de Abreu Pineda. Go ahead, Maria.
All right. Thanks, Dr. Roman. Hello, everyone. My name is Maria. I'm a 4th-year medical student, and I want to tell you about my project, Perinatal Outcomes After the Implementation of the Cardiac-OB Clinic. I did this in collaboration with my classmate, Laura Fiorini, and my mentor, Dr. Roman. So for my background here, we know that cardiovascular disease is the main cause of mortality and morbidity in the United States. In particular, we have this graph over here from the CDC, which shows causes of pregnancy-related death data from 2016 to 2018. And we see the higher causes over here being cardiovascular related. The first column over here is other cardiovascular conditions, but we do have other things like cardiomyopathies and hypertensive disorders of pregnancy here, causing the majority of deaths in our pregnant patients. So for our study, we used the California Maternal Quality Care Collaborative algorithm, which we have a simplified version over here. The algorithm includes different aspects like symptoms, vital signs, risk factors, and physical exam findings. And essentially, any combination of these, in particular, any combination adding up to 4, or more than one of these individually, is enough to warrant a consultation in cardiology. So just to kind of go over a few of them, risk factors, for example, we have age greater than 40, African-American race, pre-pregnancy obesity, with a BMI greater than 35, pre-existing diabetes, hypertension, substance use, and history of chemotherapy in the past. Or some of the vital signs, resting heart rate greater than 110, systolic blood pressure greater than 140, respiratory rate greater than 24, and oxygen saturation less than 96%. And some of the physical exam findings that we did see pretty often, murmurs or even crackles, as well as some of the other symptoms listed over here. So again, any combination of these, in particular, adding up to 4, or just any combination of them, different categories, was enough to warrant a consultation for our OB clinic combined. So for our objective, with that mindset, we decided to investigate the perinatal outcomes stratified by cardiovascular risk. And I'm going to go a little bit deeper into what that means. So for our study design, we studied all clinic consultations since the establishment of the clinic back in March of 2021, up until July of this year. And we studied demographics, all different cardiac evaluations that the patients had, as well as the perinatal outcomes were all recorded. So for our study, we stratified patients into low risk versus high risk. Low-risk patients were patients that essentially did not need any cardiac intervention, and they were just able to continue with the standard OB care. Versus high-risk patients were patients that required multiple cardiology evaluations prior to delivery, as well as patients that required telemetry either during delivery or after delivery, as well as ICU transfers. So for some of our results here, we ended up studying our total number of patients was 131. Out of these, 3 of them were actually lost to follow-up. 9 of them came only for preconception only visits, and 119 of them were seen for pregnancy management. From those 119, 98 of them were actually delivered. So 80% of this group over here. And from the 98 patients, we stratified them into low risk for 62 patients meeting criteria for low risk, and 36 of them meeting criteria for high risk patients. So this is my first table over here, which is our demographics. Essentially, we studied different things like age of delivery, race, gravidity, parity, and the number of fetuses in the current pregnancy. And this table over here includes all 131 patients. So we have low risk versus high risk for both of them. And as we can see over here, we saw no significant difference between our demographics. My table 2 here includes maternal, medical, and cardiac conditions, so all the comorbidities from our patients, just to kind of highlight a few. Some of the comorbidities that we studied were obesity, pre-pregnancy BMI actually greater than 30, chronic hypertension, thyroid disorder, history of preeclampsia and prior pregnancies, gestational diabetes, as well as some of these other ones. And for cardiac conditions, we did have a variety of them, chronic heart failure, cardiomyopathy, renal disease, valvular disease, as well as arrhythmias and the other ones listed over here. And also this table includes all 131 patients. Kind of note, the most common cardiovascular disease that we found in our patients were chronic hypertension, history of preeclampsia and prior pregnancies, chronic heart failure, cardiomyopathies, and arrhythmias, the ones highlighted with a little arrow over here. For this table here, this is mainly including cardiology testing. So all the different procedures that our patients received, essentially EKGs, echoes, CT angiograms, dialysis even. So similarly, this is actually now including all only the delivered patients. So we have 62 meeting criteria for low risk and 36 meeting criteria for high risk. We do see some statistical significance in some of the procedures as we see over here, including Holters. I did want to note for other services consulted in delivery, what that meant was essentially if we consulted any other service different than OB and anesthesia, ranging from 1 to 3 additional services in the low risk patients and 1 to 9 additional services consulted in the high risk group. This table over here shows perinatal outcomes of the delivered patients, in particular delivery outcomes, including FGR, gestational hypertension, and a variety of hypertensive disorders over here. And interestingly enough, we found statistical significance for severe preeclampsia. So our high-risk patients got a number of 33% of them develop severe preeclampsia versus 9 to 10% in the low risk. This is my perinatal outcomes with particularly delivery outcomes, similar table, low risk versus high risk. We saw some statistical significance in preterm deliveries, so less than 37 weeks and less than 34 weeks. As we see here, high risk patients, 33% of them approximately ended up with a preterm delivery less than 37, and 25% of them less than 34 versus 12 and 3 in the low risk equivalents. And this is my last table over here with neonatal outcomes, similarly low risk versus high risk. And we found statistical significance for newborns with small for gestational age category, with 16% of them in the high risk category, column versus 3% of them in the low risk. So in conclusion, after analyzing this data, we found many different success stories. I did want to highlight one in particular that kind of marked us, which was patient BC. She's a 27-year-old G2P1011 with chronic hypertension, lupus complicated by end-stage renal disease. She's on hemodialysis. And due to the collaboration of this clinic, she was actually able to be induced at 37 weeks. She's now status post a vaginal vacuum delivery. She was actually discharged on postpartum day 2 after meeting all of her milestones. So in conclusion, the implementation of this combined cardio-OB clinic definitely provided optimization of the management of the maternal cardiovascular disease in our patients and improved their delivery planning as well. And 40% of our delivered patients have requirements for long-term follow-up with cardiology. Some of the strengths and limitations of my study, starting with limitations, we did have a small sample size, 131 patients. For our strengths, we definitely have a multidisciplinary care team, which is definitely, I think, the biggest strength of this study, as well as the convenience and kind of improved communication of having everything easily available at one single integrated clinic. And we also applied the algorithm from the California Maternal Quality Collaborative. For future directions from a study, first, I think we would like to kind of compare data with a historical cohort, as well as kind of continue to analyze data as we move forward, hopefully trying to increase that sample size that we have right now, and as well as tracking patients with those long-term cardiology follow-ups. So as I mentioned, 40% of them require cardio follow-up. I think it will be interesting to see who are actually continuing to follow up and kind of monitor them down the line. These are my references over here. And with that, I want to thank you for your time, and I want to open it up for questions.
Excellent job, Maria. Any questions from the audience?
Very proud of all your work. Thank you.
Thank you, Dr. Akwadli. Our next speaker is Laura Fiorini. Go ahead, Laura.
Okay. Hi. Thanks, everybody. I am Laura Fiorini. I'm just pulling up my slides quickly. I am a fourth-year medical student, and I was also working on a similar project as Maria, looking at disparities in contraception in those with cardiovascular disease as seen in the Cardiac-Obstetrical clinic, and my mentor was Dr. Amanda Roman. So a little bit of background. In the 2017 to 2019 National Survey of Family Growth reported an overall 65.3% contraceptive use, and 50% of women were using a moderately to highly effective contraception. This was based on typical use efficacy rates greater than 90%. So moderate to high would include sterilization, hormonal therapy, which includes the oral contraceptive pill, the patch, the vaginal ring, and the depot shot, and then IUD or etonogestrel implants. Low to none would be barrier methods and timing. Okay. So the objective of this study was to evaluate the use of postpartum contraception among women with cardiovascular disease seen in the combined Cardiac-Obstetrical clinic. So study design for this, we used California Maternal Quality Care Collaborative to determine cardiology need, and we reviewed clinic consultations from March of 21 to July of 22. We recorded patient demographics, contraception plans, and final contraception methods. And again, we defined these contraception methods based on typical use efficacy rates. Highly to moderately were sterilization, IUD, implant, and hormonal methods, and then least effective included different barrier methods and timing. So for our results, we had 131 patients that were seen in the clinic. Of those, 98 women were delivered and had complete data, and those were used for our analysis. Cardiac conditions were categorized as high and low risk. High risk, they required multiple prenatal cardiac visits, telemetry, or ICU transfer, and low risk, they were considered stable and able to follow with standard OB care. So for results, so table one, during the prenatal visits, 56% of women had a planned contraception with their intended choice listed here. Postpartum, 66.3% had an actual confirmed contraception by their 6-week postpartum visit. And their preferred therapies were hormonal therapies, so including the oral contraception patch and the vaginal ring at 22%, followed by IUD at 19.4%. And then to take the IUD a step further, 9 of 19, or 47.3% of IUDs were post-placental insertions. Okay, for table 2, here we were looking at the demographics of mom to look and see if there was anything that was influencing their choice in contraception. We found that Hispanic women chose highly to moderately effective contraception methods more frequently. We had 11 total women who identified as Hispanic, 59%, 59 patients out of the 98 chose a highly to moderately effective, 39 out of the 98 chose a least effective or no contraception. When looking at the total Hispanic, there were 11 Hispanic patients, 10 of which chose a highly to moderately effective contraception. And then of those in particular, 3 were tubal ligations and 4 were long-acting reversible contraception. The other methods were some form of hormonal method. In looking further to try and possibly find a reason why this may have existed, 8 out of 11 or 72% of Hispanic women were under medical assistance. And then further, 2 patients had primary Medicare with a secondary Medicaid. And both of those patients had prior renal disease. And then there was 1 out of 11 who had private insurance. So next then, looking still into different maternal demographics with medical comorbidities and different cardiac conditions. We found that those with a BMI greater than 30 chose a highly to moderately effective contraception more frequently than those with a BMI less than 30. Again, so in this study, we had 37 out of 59 patients choose a highly effective contraception, and 16 out of 39 choose a low to no contraception. And then the most frequently chosen methods included a tubal ligation of 7, a long-acting contraception at 19 with a breakdown of 13 IUD and 6 implant, 11 hormonal, and 6 chose condoms, and 10 patients chose nothing. And then lastly, we were looking at the contraception plan, looking further into these different options that patients have, and then comparing it to their high risk or low risk cardiac status. And we found no difference in contraception when stratifying by high or low risk cardiac status. And then again, we were looking into the IUD and looking at the post-placental rates. High-risk cardiac patients had a post-placental IUD at 62.5% and low-risk cardiac patients at 36.4%, but it was not significant. So for conclusion, in our clinics, 74.4% of women with cardiovascular disease during pregnancy chose any contraceptive method by their 6-week postpartum visit. And in our clinics, 60% of women chose highly to moderately effective methods. So overall, women in our clinic chose a contraceptive at a similar or better rate than the general population. So strengths of this study, it recognizes the clinic intervention with multiple visits and discussing their high-risk nature. And during those visits, there was emphasized contraception counseling for patients with cardiovascular disease. And limitations, this was a fairly small sample size. We had 131 refined to 98 patients. And then when looking at the cardiovascular disease, for some of the more rare diseases, we only had 1 or 2 patients. So that made analysis a little bit more difficult. And then we also had unknown confounding factors influencing the choice of contraception, whether it be family dynamics or other social causes. So future directions for the study, we would like to actually investigate other factors, including influencing contraception choice. So to look further into race and why Hispanic women were much more likely to choose a highly effective or moderately effective contraception. Maybe it may have been influenced by access to care, insurance coverage, their culture. And then we would also like to evaluate patient desire for future pregnancy despite their known elevated cardiac risk. And we would like to see how that impacts their choice. So thank you for your time, and I would like to open it to questions and comments.
Excellent job, Laura. Any questions from the audience?
Thanks, Laura. I think this is a great project. I'm just wondering, if there was something different about the way that the contraceptive counseling was done in the cardio OB clinic. And if you could sort of elaborate a little bit more on that.
So I don't believe that there was anything different compared to a normal OB visit, where I think it may have just been emphasizing just the continued counseling at additional visits, I think may have had an impact, as well as then explaining that the patient would be at a higher maternal morbidity and mortality risk in future pregnancies. As far as specifics as to how the counseling occurred, I'm not sure. So
I usually see these patients in clinic with Dr. Baxter, so I can tell you at least I am very pushy with LARC or definitive contraception, because these women are extremely sick, cardiomyopathy, medications for hypertension, multiple medications, and I would like to have them in a very good contraception. And to my disappointment, sometimes they don't agree, they don't accept, and they don't want any contraception. For example, our lady who has hemodialysis and needs a renal transplant went home with depot, even though I did extensive counseling for her to have something better. And like, please come back to your appointments, because if you get pregnant again, you end up having dialysis every day during the next pregnancy. So it is still disappointing that they don't want to get a better method.
I don't want to take too much time, but it'd be interesting to see if if your cardiologist tells you you need a LARC, or your nephrologist talks to you about a LARC. Are you more likely to take that up when you're hearing it from the multiple specialists and not just your pregnancy care provider?
So having them in the room with Dr. Rapreneur and Dr. Jones, they do emphasize how sick you are, and please do not get pregnant so soon, but it's up to us to do the heavier of the consultation. Thank you, Laura. So please write your questions in the chat. We're going to move with our next speaker is Merissa Maccani. Merissa, go ahead and get your slides up. Thank you so much for everybody's questions.
Hi, everyone. My name is Merissa. I'm just going to share my slides now. Let me just share my screen. Okay. Sorry, can everyone see that? Okay, thank you guys. Okay, so thank you. So my name is Merissa. I am a third-year medical student at Jefferson. And I worked on this project with my primary mentor, who was Dr. Beth Schwartz. And the title of our study was Parental Perceptions of the HPV Vaccine for the Prevention of Anogenital and Oropharyngeal Cancers. And this was ultimately a qualitative study. So to kind of give you guys some background on the study itself. So this study, as I mentioned, was entirely focused on the HPV vaccine. And HPV itself is the most common sexually transmitted infection in the US. And as many of you know, it's implicated in the development. Oh, so sorry, just open the chat for a second. Sorry, I can't get rid of the chat. There we go. Okay. And as many of you know, it's implicated in the development of anogenital as well as head and neck cancers. And kind of the entire thinking behind this study was that even though the HPV vaccine itself is extremely effective in preventing a large percentage of anogenital cancers as well as head and neck cancers, vaccination rates for this vaccine specifically are still very low, and that's particularly among male patients. And that's when you compare it to other age recommended vaccines kind of at the same time. And to sort of prove that point, I included a graph on the top right, which really demonstrates that. And if you look at that solid black or solid blue line at the top, that's vaccination rates for just one dose of Tdap. And so you can see that it's quite high. But then if you look at really, I would focus on the two lines that are alluded to with the two arrows. Those indicate individuals who have either received all HPV vaccines or at least one, and you can see that it's much lower than at least people that have received one dose of Tdap. And so kind of in general, that vaccine has a much lower rate of uptake. And then another component of this is that when we did prior research before we even started this study, we found that a lot of the reason that patients and their families don't really tend to get this vaccine is it's for a lot of reasons, but primarily just due to knowledge gaps and acceptability for the vaccine. And that was especially true for men and boys. And we found that a lot of times parents are recommended this vaccine, but when it came to having male children, there was a lot lower rate of uptake. And especially in terms of parents understanding the connection between HPV and head and neck cancers, that was also a knowledge gap that we found. And so kind of to also illustrate that point, if you look at the graph on the bottom right, again, there's a lot of lines, but if you just compare any color combination with the dotted lines with solid lines, you can see that between men and women, the rate of vaccine uptake is it's lower in men kind of across the board, which is sort of a unique part to this vaccine that we don't always see with other recommended vaccines. So just kind of additional background. The recommended age for the HPV vaccine itself is 11 to 12, and parental consent is required. So we ultimately wanted to understand what is the thought process that's going into parents deciding to either vaccinate or not vaccinate. And that was really kind of the genesis of this study. So to give some, just the objective of this study was to explore parental knowledge, perceptions, and the decision-making process around the HPV vaccine for both anogenital and oropharyngeal cancers, and to understand the differences in knowledge, beliefs, and vaccination intentions, specifically between male and female children, was really what we wanted to focus on. So as far as the methods, what we did is we recruited parents who had children that were aged 8 to 18, and these adult participants were recruited from Thomas Jefferson University, specifically the OB/GYN department, as well as Memorial Children's Hospital. So some of you may have seen our flyers actually kind of just around different clinical settings. I myself have seen some that are still actually up, which need to be taken down. But participants ultimately they participated in semi-structured telephone interviews regarding their knowledge and perceptions around the HPV vaccine. And then the data from those interviews were transcribed into a service called NVivo, and we ultimately analyzed the themes from those interviews and created some global themes from that. So to kind of give an illustration of how we came up with those themes, just focusing on the graphic on the right side. So we started with our qualitative data in our interviews, and we basically put that into NVivo, and then we went through an initial coding system between all of the researchers involved. So we all individually came up with codes, and then we went through those multiple times to come up with global codes that represented some overall themes that we found among the participants' interviews. So some sample questions, just to give you an idea of what we asked participants, included, can you tell me about your understanding of what potential diseases / conditions the HPV vaccine is intended to prevent? As well as to your understanding, what are perceived benefits to your child receiving the HPV vaccination and what are its risks, as well as do you feel there are certain benefits or risks that are more applicable to girls versus boys? So these questions really generated very open-ended discussions and quite a lot of different responses, which are really interesting to read. So as far as results, overall, we had 31 parents that ultimately enrolled and then completed an interview in this study. And we had 6 major themes that came out just from doing our global iterative review process of our interviews. So one section where we really found a lot of information was in terms of parents' knowledge about the HPV vaccine. So kind of across the board, there was definitely a consensus that there was some confusion as to what the HPV vaccine was for. Some parents could name everything it was intended for, and then some parents really didn't know what the purpose was. So there was kind of a range, but some quotes included one parent saying, I think for cervical cancer prevention, and then another parent saying, I think that's a vaccine that helps prevent chickenpox, the measles, and other stuff. So as you can see, kind of a range of beliefs. There was also some themes that came out in terms of the perception and attitudes towards anogenital and oropharyngeal cancers. Really overall, one thing that was interesting is parents kind of across the board said cancer is cancer. They didn't seem to have a preference as to whether a vaccine could prevent one cancer versus another. They all seemed pretty in agreement about, wanting to prevent any form of cancer in their children. Another theme that came out was the role of child's gender in HPV vaccination. So some parents kind of had the thought that maybe girls are vaccinated before boys, or this vaccine is intended for girls more so than boys. And a quote to illustrate that is a parent saying, I could be completely wrong, but I thought it's different in boys and girls before boys, around puberty time, whenever that hits 12 to 4, I guess. Another thing that came out is the decision-making process towards vaccinating children and adolescents with the HPV vaccine. So one parent said, I actually chose not to vaccinate her because at the time I didn't know enough about it. But whether it was a boy or a girl, I just felt it was too new of a vaccine and didn't know the long-term effects of the vaccine and chose not to get it done. And that was really reflected among a lot of parents, just not so much that there was one specific thing about the vaccine that they didn't like, but just that they felt enough was explained to them, or it was just kind of given to them as, hey, you need to get this vaccine, but they really didn't understand the risks or benefits. And so that brings me to theme 5, that communication with healthcare providers around HPV vaccination came up a lot. So one participant said, I trust my daughter's pediatrician, my healthcare provider is my first point of contact usually, but typically they also access other sources of information, maybe news articles, and other things like that. So a lot of patients really very much highlighted that pediatricians were a trusted source of information. Some, as I mentioned, went to news or friends, but really across the board, pediatricians were people that were mentioned as trusting sources of correct information. And then influence of social networks, I guess surprisingly to me, I sort of thought that more people would mention that they lean on friends and family to inform their decision, but a lot of people said that it was just kind of secondary information and they trusted their own research or their pediatricians more so than their friends and family. So overall, significant gaps in knowledge about the HPV vaccine's indications and its efficacy, especially for males in oropharyngeal cancer prevention. Participants also noted that information about the effects of the vaccine being able to prevent oropharyngeal cancers would positively influence their decision to vaccinate, especially male children. And then parents had concerns about the risks of the HPV vaccine, especially long-term side effects on future fertility. That came up quite a lot as something that parents feared, just kind of from their own thinking about the vaccine. And then, as I mentioned, they cited their children's healthcare providers as important sources of information that they trusted and were really critical to their decision making. So some strengths and limitations to this study. The interviews that we did with patients were very open-ended and to my opinion, allowed for a very thorough characterization of beliefs surrounding the HPV vaccine, and they were very they were structured, but in a way that allowed people to really give their thorough opinions. And that's kind of mentioned in the second bullet point, very free flowing. And then also parents of targeted vaccination age were included. So that allowed us to really talk to parents that were at the exact moment that they were having to decide if their children wanted this vaccine. Some limitations were that we only included participants from the TJU Nemours system. So obviously that brings in socioeconomic factors. We really were limited to a certain geographic area in terms of the patients we interviewed. So expanding this beyond just this region would be a good future direction. And then interviews were conducted over the phone rather than in person, which may have affected kind of the responses that people gave. And it was, we weren't really able to watch body language and to get a better sense of what people's true responses were. And then demographic data was not correlated to responses. So we did have some participants who were physicians, so that obviously influenced their knowledge about the vaccine. So going forward, just correlating that would probably be helpful. So some conclusions: this study identified knowledge gaps related to the HPV vaccine in parents, children, adolescents, especially in terms of decision to vaccinate males, their understanding of oropharyngeal cancer prevention, and just the risks that were lacking. And as I mentioned, pediatricians were really highlighted as an important source of information. And so one, ultimate thought that came from this this project was that pediatricians should really feel empowered that what they are telling their patients is something that they really value, and just to take the time during their visits to really explain the vaccine, and not just to gloss over it, because parents really do listen to what their pediatricians are saying. And then ultimately developing more formal training programs for providers so that they feel equipped to understand what are parents worried about, what information do they need to really accept this vaccine. That may be beneficial going forward. And then references there, And just kind of some future directions that I did mention, but didn't write out, are just educating providers about how they can be better informed to really understand what are parents' hesitations and what information do they need to know that will help them kind of make an informed decision and ultimately choose to vaccinate their children. So that is it. I will stop screen sharing and open up for questions.
Excellent job, Merissa. Any questions for Merissa? We have 1 minute for questions. Okay, very good. Please write your questions in the chat. Our next speaker is Emily Ferguson. Emily, go ahead.
All right, so my name is Emily Ferguson. I'm a second-year medical student here, and the title of my project is Assessment of a New Methadone Stabilization Protocol for Pregnant Patients with Opioid Use Disorder. And I've been working on this project with Vivian Yan, another M2, and Dr. Neel Iyer. So some background on the project. Methadone stabilization in pregnant patients is an important therapy for opioid use disorder because it can help prevent the development of unpleasant withdrawal symptoms and reduce the drive to use illicit opioids, thereby protecting their sobriety from illicit opioids and helping to reduce the harm done to both mother and the developing fetus by the use of these substances. But methadone stabilization in pregnancy is complicated by the fact that pregnant patients clear methadone from their systems more quickly than non-pregnant patients do, and they often require higher doses to achieve the same therapeutic aims. Historically, however, methadone stabilization protocols for pregnant patients have not taken these biochemical differences into account, and protocols for pregnant patients have been developed based on data from non-pregnant people. This can result in too slow titration of methadone during stabilization, which ultimately threatens the sobriety of pregnant patients with opioid disorder and can increase the risk for a return to use of illicit opioids and the harm from that use. Jefferson has been an important player in methadone stabilization in the Philadelphia area for pregnant patients for a long time. In the fall of last year, Jefferson implemented a new methadone stabilization protocol for pregnant patients that involves more rapid titration with the goal of achieving stabilization in a shorter time frame. So our project aimed to compare this new rapid titration protocol with the previous protocol in terms of a few different outcomes. The primary outcome that we looked at was time to methadone stabilization. So the number of days that elapsed from the time a patient presented at the hospital for stabilization to the time that they achieved a dose of methadone that helped control their symptoms and helped them maintain their sobriety from illicit opioids. We also looked at medical elopement, so the rate at which patients in either group would leave the hospital prior to reaching a stable methadone dose, and readmission for methadone stabilization over the course of the same pregnancy, presumably following a relapse or some sort of destabilization. We also wanted to make sure that the rapid titration protocol would achieve these outcomes while not increasing the risk for overdose while the patient was hospitalized and being stabilized. So we conducted a retrospective chart review of 89 pregnant patients with opioid use disorder who sought methadone stabilization at Jefferson. We had 36 patients in our control group who were treated under the previous protocol from June 2020 to August 2021. And 53 patients in our rapid titration group who were treated from September 2021 through May of this year. So this is just a schematic showing the two different protocols. So under the previous protocol, patients would receive a starting dose of 30 milligrams when they presented at the hospital, and their withdrawal symptoms would be rated using the clinical opiate withdrawal score measure. And if their CAL score remained over 8, they could receive a PRN dose of 10 milligrams of methadone every 6 hours. For the rapid titration protocol, patients were given a starting dose of 30 or 40 milligrams based on their initial CAL score, and then a PRN dose of 10 milligrams every 4 hours. For both of these protocols, a patient's daily dose on a given day would start at the cumulative total of their doses from the day before. So for example, if a patient received a starting dose when they presented of 30 milligrams and then 3 PRN doses, the next day their starting dose would be 60 milligrams. So looking at our results, we did not detect any differences in baseline characteristics between patients treated under the rapid titration or the standard titration protocol, except for gestational age, with the patients in the rapid titration group presenting about 5 weeks later in their pregnancies than the standard group. In terms of our outcomes, we did not detect a difference between the groups in time to stable dose, but we did detect significant differences between the groups in terms of medical elopement and readmission for restabilization after controlling for gestational age. So in the case of these two outcomes, the rapid titration group had nearly 50% fewer medical elopements and also had fewer readmissions for methadone restabilization. So those two findings definitely supported our hypothesis that rapid titration could reduce those outcomes, but our primary outcome was not supported. We did conduct a preliminary power calculation that showed that we needed at least 50 patients in each group to adequately assess our outcomes, and we believe that that may have played a role in not finding a significant difference in terms of time to stabilization. So that's certainly one of the limitations of our study, and we'll actually be abstracting data from 128 additional charts over the coming month in order to reach those thresholds and hopefully more definitively elucidate any potential differences between the two groups. Another limitation would be that we couldn't account for how COVID may have affected patients' presentation to the hospital and if and when they chose to come for stabilization. And we also did not account for how readmission rates could be affected by the care that patients received once they were stabilized and left the hospital. So some patients chose to go to outpatient methadone clinics, whereas others chose to go to inpatient rehab centers. And for example, a patient who chose to go to an inpatient rehab center may have been better supported to maintain their sobriety, or conversely, may have gone to a center located in a different area and not been physically present in Philadelphia to represent at Jefferson for stabilization. So we certainly would want to look at that in future iterations using our data. We also collected information on the supportive therapies that patients received while they were being stabilized. So that could certainly play a role in how quickly patients were stabilized or medical elopements if they did receive supportive therapies that helped control their withdrawal symptoms. And we also collected data on other substance types that patients used. For example, we had many patients that also used benzos, and so that could certainly be a factor that plays a role in stabilization. And as I mentioned, we will be assessing some additional charts to look at the time to stabilization differences more clearly. And if we don't detect a difference in time to stabilization between the two groups once we've looked at that data, we would certainly want to assess why that might be the case. So that's all I have. Thank you for listening, and I will take any questions.
Excellent presentation, Emily. Any questions from the audience?
Hi, this is Norm Rosenblum. I had just one question. Very nice presentation. Was the only difference in the maintenance, it was every 4 hours versus every 6 hours? I mean, on that first graph you had, it was 10 milligrams every 6 versus 10 every 4. Was that the only difference? Was the more frequent dosing?
Yes, that was the only difference in the maintenance dosing. And then there was the difference in the starting dosing, where some patients who had higher Cal score on their initial presentation would start at a 40 milligram starting dose instead of 30.
Thank you.
Well, congratulations to our medical students. Every presentation was superb. Your research is really fantastic. You worked very, very hard, and you will be changing what we do here at Jefferson. Thank you, each one of you.
We have 4 minutes for questions from any of our students presenting today. And I would like to have a big applause to all our students. They did wonderful. I can see the future for research and clinical development in these 5 students. Excellent job, and to their mentors for their support and their guidance. Thank you so much, everybody, for your attention. And please send any other questions for our students. Okay, if no more questions, that concludes our session for today. Congratulations to all our 5 students. Great job. Thank you, everybody. Have a good day.
Thanks, Dr. Roman. Have a good one.